Thank you, Mr. Chairman, dear colleague. You are welcome in Jerba. And I will try to talk during these 10 minutes about DOAC management in surgical context. So in the last decade, DOACs are rapidly gaining in ground and replace classic VKA. And even in a patient from Africa and Tunisia, we have a growing prescription of DOACs because we have contributes of generics in giving accessible this drug. This will increase the number of patients presenting to surgery who are exposed to NOACs. And we estimate that between 10 and 15% of patients will require treatment interruption during the year with DOACs. So over the years will be a frequent situation to manage in our practice. About DOACs, we know that we have three approved DOACs. One is thrombin inhibition, and the other three are factor 10 inhibition. And we see here that they are different from half-life, during, and even with renal elimination, which can affect our treatment in case of cessation or in case of hemorrhage. So we know that apixaban and rivaroxaban have the lowest renal dependence of these drugs. And this affects also, according to renal function, the dose to use. I just here this slide just to remember that DOACs are not only prescribed for IF, they are also prescribed for venous thromboembolism and for prevention and even for vascular protection. But these are lower dose and they can easily manage it. So let's see the practical aspect of preoperative DOACs management. First of all, first question, is it an emergency or unplanned surgery, or is it an unplanned surgery? It's very different. And I will try afterwards to respond to these six questions. Do we need to stop, and when? Do we need to reverse? Do we need to bridge the treatment? Do we need to assess those? How to deal with complication, and when can we resume and take the treatment again? For the urgent surgical, there are three situations. There is acute emergency procedure, which will be done in the minutes. And for this, we have to blood sampling and reverse NOACs and treat the patient with surgery, and then check again the coagulation panel. If the operation can be reported 12 or 24 hours, it will be better for the patient. But we at this time will do another check panel and then operate a patient in a better condition. If the intervention can be delayed 24 hours or more, we can treat it as a planned surgery, and we operate the patient in better conditions. So the practical approach management will try to minimize the perioperative thromboembolism and bleeding. And this is the case of urgent or planned. We have to assess the patient thromboembolic risk and the surgery-related bleeding in these conditions. First of all, the patient assessment of risk thromboembolism. Here we have the ESC guidelines. The patients are classified in three types: high bleeding risk with more than 10%, moderate between 4 and 10, and lower than 5%, there is a low risk. And in case of atrial fibrillation, you know that SHAT-VASc more than 7 is a high risk, middle risk between 5 and 6, and 1 and 4 SHAT risk is a lower. In the case of venous thromboembolism, it depends on the recently of the embolism events, and is in the existence of a thrombophilic predisposition. So on the other hand, we have to assess the risk of surgery or anesthesia-related bleeding. And here again, we have a classification of three categories: high risk patient like cardiac surgery, vascular surgery, urology, and neuroaxial anesthesia here, very important to know. And in the moderate, we can have like colonoscopy or coronary angiography or PCI, complex PCI. And the minor or low, you have dental, for example, dental procedure and even pacemaker. For neuroaxial anesthesia, it's always classified as a high risk bleeding procedure. And the spinal or epicardial anesthesia is contraindicated in patients under NOACs. So we have to stop at least 3 days before neuroaxial anesthesia rivaroxaban. If it's the bigatron, it will be between 3 and 5 days, especially in patients with renal failure. So we can use the pharmacokinetics-based approach, as said Rafiq, which correspond to stopping the treatment 4 to 5 elimination half-life of DOACs in case of high-risk patient, 3 times half-life in case of moderate, and only the day of intervention in minor. And this will be, of course, depending also on renal function, because the half-life will depend also on the renal function of the patient. So according to the American guidelines, we have here the 4 drugs, and with the above you have apixaban that we can stop, of course, the day of the procedure, but the day before. It's low to moderate. We don't take the pill. And if it's high-risk surgery, we'll stop 2 days before and then the other day. If it's on the bigatron, we have to stop even 4 days, sometimes 5 days before. And here we have the European Society guidelines. You have the minor risk, the low risk, and the high risk, and you have the 4 drugs. And you have the stopping the treatment for all the patients during the procedure, the day procedure. But in the minor risk, we can just stop the pill of the evening, skip the pill, and then take it 6 hours after. In the low risk, we can not take the treatment in the previous day, in the day of the procedure, and then take it in the evening. And in the high risk, we should stop 2 days before, and maybe 3 or 4 days before, and sometimes we have heparin just for preventive post-surgery. As I said, the delay will depend also on the renal failure. So for the bigatron, for example, we have to stop more than 96 hours, and in the high risk here, we have to stop more than 2 days if it's impaired renal function. So this is a short clinical case, 75-year-old female with IF under apixaban or rivaroxaban with hypertension, diabetes, and shed VASC at 6 with a clearance 45. She is programmed for hip replacement on Friday at 8 a.m. with spinal anesthesia. What we recommend, what the American guidelines recommend, is to stop the drug 1 or 2 days before. I will say 2 days for this patient because we have spinal anesthesia. It's a high-risk patient. And even for rivaroxaban, it's the same. Oh, so do we need to bridge when stopping? All the guidelines are saying no. No bridging, because the bridging is considered to have much more hemorrhagic complications. So I will say that we should consider prophylactic treatment in post. It's not a bridge, it's prophylactic treatment after the surgery. Also, all the guidelines are coming from the POST study. POST study is very interesting and sample study of 300 patients, which was which was omitted for 1 day before a low bleeding risk, or 2 days before low bleeding risk. And restarting DOACs 1 day after low risk, or 2 days, 2 or 3 days after, with no perioperative bridging. And look at the bleeding. The measured bleeding are about 1% only, and the thromboembolic are about 1.6%, so very low. So this is a very effective strategy. We have also study about inserting pacemaker, and we have in this study, in the Bruce study, that whether we stop or no, if the patient don't take the treatment the day of the intervention, the complications are very low. hemorrhage is very low and embolic events are very low, so we can continue the treatment or stop it if it's really a high-risk patient. Do we need routine DOAC coagulation function test? It's no, it's only for urgent or emergency surgery because it will inform us about how to reverse the treatment. How to reverse the treatment? If we have a surgery to do in the minutes or in the few hours, we have to inhibit with the prothrombin complex concentrates, and check the level of the anticoagulants. It's about 20 nanogram per milliliter. We have to use paradoxan or ondexan, but all these drugs are not available in Tunisia, so we are always using PCCS. Now, how to deal with complications? I think that Rafiq talked about this, but in life-threatening bleeding, DOAC's reversal is the key point of the treatment. And in Tunisia, we have only PCC for prothrombin complex concentrate and to treat the patient with Yggdrasil if possible. Just a special thing about patients who are under monotherapy, coronary artery disease with stents, they are under monotherapy. We have to think when stopping the DOACs to keep the aspirin or to put the aspirin during peri-surgery, because if we do not do this, maybe the patient will have thromboembolic events during surgery. So, in conclusion, while surgical intervention requires temporary discontinuation of NOACs, many less invasive procedures carry a relatively low bleeding risk and can be done without stopping the treatment. This is very important. Standard post protocol is simple and safe in the majority of cases. However, patient characteristics and surgical factors need to be taken into account to determine when to discontinue and to restart NOACs. NOACs interruption period may require adaptation based on the individual benefit-risk ratio of the patient, especially of patients with impaired renal function. And don't forget, we have always special situation and special patient, and to move from simple standardized protocol to individualized protocol. And I hope that new anticoagulant in development may offer us more ability to manage this patient and to reverse. Thank you.